Hello, good evening, every doctors. This is Dr. Jeon. This is a very long time. As a long time the international speaker of the Osstem, I feel very happy to join the online Osstem meeting in 2020. Nowadays, we are in very tough time. We know the reason, the coronavirus. So many dentists around the world are having a very hard time nowadays. So I really want you to overcome this situation. So this time will be a very helpful opportunity to every doctors. Before starting today live surgery, I want to make some the preview about the 15 minutes. The today live surgery is the upper full mouth replacement. So impression taking for immediate loading, and then maybe 1 week later, I will deliver immediate loading. And also upper anterior, the ridge is very thin. So maybe sometime it require GBR or ridge splitting. I will determine at the time of the surgery. So I want to check the several factors for the successful full mouth rehabilitation and immediate loading. So general consideration. So this is the edentulous jaw states, upper and lower jaw. So briefly, I want to make some the categorize the 6 area. Zone 1, this is the intersinus area. Lower zone 1, interforamen area. And upper zone 2, this is the sinus area. And lower zone 2, this is the above the inferior alveolar canal area. So anyhow, this is 6 area. This is edentulous state. At this time, usually the bone resorption pattern starts from the initially horizontal bone resorption first. Upper jaw centripetal resorption, lower jaw centrifugal resorption. According to the bone resorption pattern, so the surgical technique is determined. So sometime upper zone 1 area, horizontal GBR. Upper zone 2 area, according to the residual bone height to the sinus floor, sometime crestal approach, sometime lateral approach, sometime conventional drilling for the bicortical anchorage. Lower zone area, according to the dimension to the inferior canal, we can place the short implant, sometime require the GBR. Anyhow, this is the horizontal bone resorption pattern. So this is the basic strategic approach for the full mouth edentulous patient. And today, upper jaw case, zone 1 intersinus area, zone 2 sinus area. Maybe upper zone 1, maybe some concavity because of the centripetal resorption. So I will apply horizontal GBR. And upper zone 2 area, today case, very fortunately, the residual bone height is very sufficient. So just the conventional implant placement is necessary. So this is the edentulous maxillar, sometime 6 implant, sometime 8 implant. Of course, the implant number regulate the occlusion range. So today I will place 8 implant upper jaw area because this patient, the lower dentition is natural dentition, second molar to the second molar area. So sometime upper 8 implant, lower 6 implant. This is one of my favorite implant number coordination. Sometime lower jaw, 8 implant is also okay. So today my favorite position is, this is the second molar, second premolar, first premolar, lateral incisor. So and then next one, for immediate loading today, after surgery, I will deliver impression taking. Of course, this impression taking require open tray first. So by the 3D printer, I will already fabricate the individual tray. Upper jaw, because of the divergence of the implant angulation, transfer impression copying or closed tray technique is not proper. As you can see, this is some undercut. So upper jaw implant impression taking require open tray technique is better. So the pick up impression copying insertion and then guiding pin remover and then take an impression. Today I will follow this situation. And then sometimes implant position is highly variable according to the bone crestal dimension and the straightness of the alveolar bone and then vertical bone dimension. Sometimes occlusion range, first molar to the first molar. At this time, sometimes anterior segment with the 2 implant or posterior segment with the 3 implant. There are too many combinations available at this moment. Sometimes you can change the implant position according to the, depends on the bone dimension. Anyhow, 8 implant means we can make 3 pieces for the final processes. Sometimes central incisor. Usually lateral incisor area, bone is very thin. Sometimes you can control, you can change the implant position according to the bone dimension. And then sometimes you can skip 4 anterior teeth area, 3, 4, 5, 6. So anyhow, this is also, you can deliver 3 pieces for the final processes. And this is my favorite implant position. With this 8 implant, the occlusional range we can make from the second molar to the second molar area. Of course, at this time, we can make 3 pieces for the final processes. So anterior segment 4 implant, posterior segment 2 implant. For finally, 8 implant with 3 pieces approach. And then today also, after surgery, I will take an impression for the individual tray with the open tray technique with a fixture level impression. This is the timetable of the full mouth rehabilitation. Initial view, and right after surgery, sometimes we can deliver immediate denture. Maybe this immediate denture wearing 3 months or 6 months. And then several months later, we can deliver second surgery. This means we deliver the healing abutment and then impression taking. Of course, fixture level impression. And then we deliver fixed temporary bridge. This is the provisional restoration. I think the full mouth rehabilitation, most important one is provisional restoration. This provisional restoration, we can check the many factors. TM joint problem, and the lip support, and 3 function, chewing, mastication, swallowing. And then, after the comfortness, this is the provisional restoration, we can change the final restoration. But today, I will go the immediate loading. Immediate loading means we can skip many stages. Immediate denture stage, second surgery stage. So after surgery, we directly go to the immediate loading. And then that means adaptation time is very sufficient. So in point of the patient comfortness, highly comfortable, this one. And then final processes. I think the full mouth rehabilitation, immediate loading, this is the same family. Because cross-arch stabilization, we know the cross-arch stabilization. That means beyond the midline implant placement, it can make immediate loading. So several implant placement, rigid splinting, mutual protection. That means we can make immediate loading. Exactly same result to the conventional loading. So full mouth rehabilitation with immediate loading, highly predictable. So this is a very similar case of today. So this is the flap knee surgery. And then after surgery, direct impression. Individual tray, and then open tray. And then this is a pick-up impression from the fixture level impression. And then place the implant, impression taking. And before going home, we have to deliver healing cap. And then within 1 week, we deliver custom abutment or milling abutment with the immediate loading processes. So this patient also followed this sequence, immediate loading and the final result. Of course, from the provisional restoration to the final restoration, just a direct impression, sectional temporization, sectional impression, sectional final processes is necessary. So according to this rule, I will follow step by step. Anterior segment deliver first, posterior segment deliver secondarily. Okay, briefly review today's cases. So this patient, 7-year-old male patient, the systemically generally healthy state. This patient wear a denture 15 years. And then, very fortunately, the residual bone height to the sinus floor is very sufficient. And then, molar area to the premolar area, crestal dimension is relatively good. So, at this time, the molar area to the premolar area, flap knee surgery. And then upper anterior 2 implant area, it requires GBR or ridge splitting. And then, after surgery, I will take an impression. So let's briefly view of the CT scan from the before surgery. So molar area, premolar area, the crestal dimension is good, but anterior area, ridge is very narrow. At this time, I will determine ridge splitting or GBR technique. This patient, this is the old used denture, and then this denture, maybe the transverse narrowing a little bit. So finally, it requires 3 pieces approaches is better. And then this patient already, by the 3D printer, this denture duplication. This duplicated denture make a vertical dimension maintenance. And also this individual tray making from the 3D printer, it will make a possible just impression taking for a fixture level impression. Okay, dynamic of the immediate loading. Usually surgical aspect, prosthetic aspect is different. Surgical aspect, more implant, it looks good. But prosthetic aspect, more implant, it looks more complicated. So what? What is the optimal number for immediate loading? Upper jaw, 6 implant is necessary. Lower jaw, 4 implant is okay. Today's case is the upper jaw. So I will place 8 implant. Among them, I will select 6 implant and then take an impression. And then within 1 week, I will deliver immediate loading processes. Thank you, everyone. Please enjoy today's live surgery case and wish me luck, please. Okay, I will move to the operation room. Okay, see you within 30 seconds. Maybe it is a central incisor. This is the lateral incisor. Maybe this is a canine. So maybe this is the first premolar area. So today my first implant, number 4, number 5, number 7 here. From the CT scan, the crestal dimension is good. eye 보세요. 오픈 eye 보세요. 여기 물 좀 뿌려줘야 되겠다.
아이 보세요.
오픈 와이드. 됐어. 뿌려줘요. 물 좀. This bone, I want to collect this bone. This is a very good bone. Irrigation. eye 보세요. Okay, next drill is a 3.5, the taper drill. eye 보셔요. Okay, 4.0. In the Fleming surgery, usually we can expect the soft tissue thickness. So if we want 8.5 implant placement, maybe implant drilling depth around the 10 millimeter is okay. Okay, final drill, 4.5. Okay, let's place the implant. This is the 4.5, length 8.5. 모두 바꿨나요? Second implant. 보세요. Open wide, please. The most important factor for the flap surgery, you have to evaluate the keratinized zone. So good keratinized zone means inside the bone it looks good, usually, because the overlying soft tissue influence the underlying bone tissue area. 살짝 다물어 보세요. 천천히. 네, 좋습니다. 오픈 아이 보시고 오픈 와이드. The flap surgery, anyway, this is the expectation for the bone area. So a little bit deeper installation is necessary. A little bit deeper. Okay, saline, please. This patient wear a denture, maybe about 15 years, so a little bit transverse narrowing. But this is the safety zone, so maybe the transverse narrowing dimension is not high, so this kind of the implant angulation is okay. Okay, the upper left side, drilling mode. Okay, let's briefly check. This is the central incisor, lateral incisor, maybe canine. Okay, this is the first premolar area. Number 4, number 5, number 7 here. 오픈. 고맙습니다. Okay, next step drill, 2.2, 8.5. 편하게 재채기 하셔도 됩니다. Open, please. This one, I will collect. This is the very good rotational spawn. Okay. Okay, next step, 3.5. 보세요. Open, please. Okay. 너무 잘하고 계셔. During the surgery, you have to check the bone perforation, lingual side or buccal side. So at this time, you check the bone perforation area. Okay. Good. Next drill, 4.0. The final drill, 4.5. This patient alveolar stone resorption. So actually the second molar this is right, but I think that this is better because this area is not proper for the implant placement. One more checking. You have to check the bone perforation. Okay, looks good. Good. Okay. Okay, first implant, upper left side first. 보세요. Open wide. For a successful immediate loading, you have to get a good stability of each implant. So this 6 implant, so minimum requirement maybe 20 Newton, but optimally 30 Newton. So usual implant placement at 90% and engine-driven placement, but other 10% hand-driven is better. Okay, 4.5, 8.5. Good. 다음으로 보세요, 아버님. 천천히. Okay, eyebrows open, please. 이리게이션 좀 해줄까요? I think that this implant, a little bit distalization is better. Okay, I want to change the implant position. 임플란트 제거 모드로 바꿔주세요. 리무벌. I want to change the position. 보세요, 아버님. 다시 드릴링 모드로 바꿔주세요. 오픈 플레이. 보세요. Okay, 2.2, 8.5. Three point five. Four point zero. Final drill 4.5. I want to check the connection, the first hole. Okay, no connection. This is the first hole, second hole, no connection here. Implant 식립 mode. 해보세요. Nowadays, we can use the digital guidance. The Osstem one guide is very, very predictable. Sometimes you can try this one, but the bone is good or the attachment keratinization is good. Sometimes the analog method is also available. So you can select the proper one according to your level. 해보셔요. I think this 6 implant stability is good. the final depth control by the fixture driver, because we have to use the line for the depth control. So at this time, we can see the 3 line here. So fixture engage this area. So this is the soft tissue level. So this is the automatically 5 mm depth control is available. So at this time, we use this one. So at this time, the final upper line almost touches to the soft tissue area. That means this line is the 5 mm from the soft tissue level, automatically 5 mm deeper from the soft tissue line. This side too high initial stability, so that is a reverse torque. Because I like 30 Newton. Reverse torque, 1 or 2 times turn, the counterclockwise, and then we try here. Okay, this is optimally 20 Newton, 30 Newton here. Good. Also, second one, more deeper. Okay, too high. Reverse torque here. And then retry. Okay, optimally 30 Newton. 아니야. 이거 잡아줘. Okay. Open wide, please. Okay. You have to feel at the time of the tight torque wrench. Please feel the initial stability. Okay, almost 4 or 5 mm deep from the soft tissue level. Reverse torque. Retry here. 이거 픽처 드라이브 하나 더 가져와야 되겠다. Okay, upper healing cap, please. Healing cap. 보세요, 아버님. Not too tightening because after surgery we'll take an impression for the fixture level impression. So grossly, slightly tightening is okay. 이건가? 좋죠? Okay. Number 24. Depth control. 3 mm deep. Still high. So reverse torque. 90 degree here. And then we try. Good. 30 Newton. Reverse torque. Retry. Good. The final implant, the 27 second molar area. Okay, this is the about 30 Newton here. 어머님 아이 보셔요. For the soft tissue opening, the healing cap is necessary. Not tightening, slightly engagement is necessary. 아이 보세요, 어머님. This patient within 1 week, maybe 5 days later, I will deliver immediate loading processes. What is the big advantage of immediate loading? Of course, sufficient adaptation time, but I think cost down effect is very big. At the time of the immediate loading, you can use the custom abutment, and this same abutment also you can use at the final for the final processes. Okay, now I want to start upper anterior. This is central incisor. Maybe lateral incisor here is the best place for the 8 implant placement. So at this time, motor number 9, periosteal elevator. We can check the anterior nasal spine at this time. Do you have some guideline about the anterior vertical bone dimension for the implant placement? I think 8 millimeter is the minimum requirement. Below the 8 millimeter, we can skip is better because this area, minimum length 7 millimeter is okay. But today, the vertical bone height is good. So at this time, you can check the nasal floor here. Okay, this is a nasal floor. Can you see? This is nasal floor. This is the nasal incisive canal, this one. At this time, I want to try this area, GBR technique, this area, 리치 스플리팅 technique here. 시간 좀 봐줄래요? 몇 분 남았는지? 몇 분 경과했는지 좀 봐줘. 몇 분 경과했는지 물어봐 주세요. Open wide. Okay, central incisor, this lateral incisor. So at the time of the side cut drilling, we have to maintain the lingual wall. Torque control is necessary. We don't want the palatal perforation. 네? 몇 분 지났는지를 좀 체크해줘. 내가 시간 계속. Okay, 3.5 drill. Please check the palatal perforation. Okay, final drill 4.0. Usually upper jaw no require the decortication. 마취 좀 더 줄까요? Okay, the patient feels some pain, so local injection. Okay, next one, 4.0, 10 millimeter implant. Section. So for a proper drilling by the side cut drilling, we can make an intentional the buccal plate loss. This area we can finish by the GBR technique here. 조금 시큰하시죠? 다 됐어요, 아버님. Okay. Please check the palatal perforation or not. Palatal is very good. Okay. 커버 스크루 줘요, 여기. 커버 스크루 주세요. This area, GBR technique is better. Okay, the genograft. The 풀고, the graft, please. 그거 좀 직접 빨리 열 까주세요.
저 이리게이션이요.
이거 드릴링 모드로 바꿔줘요.
조금만 빼주세요.
좀 저기다 부어주세요.
네, 다 제가
살라인 좀 보죠. 바이오 커버 다 까주시고요. 하이 보세요, 아버님. Open, please. Section. 자, 드릴링 모드 해주시고. 네. 두 포인트 드릴. Please check the palatal perforation or not. You check here. Okay. And then 3.5. The final drill. 4.0. Maybe the remaining bone is very hard bone. Okay, final implant. 해보세요. Open, please. 토크. Very slow action, like here. 조금 시큰하시죠? 이게 뼈가 좀 예민해서 그래요, 아버님. 이거 뭐 신경 다치는 거 아니고요. 오케이. This is the typical ridge expansion. Okay, I will place the cover screw. Now I want to start the GBR with the general graft, the Prugo company, the graft, the general graft. There are many methods for the GBR area stabilization. This is the autogenous span from the drill. So very sufficient to drill with the autogenous span we can get during the drilling. The basic principle for the GBR, the first one, over contouring. Second one, the membrane stabilization. 여기도 하나 걸어줘. This the Prugo the graft. I used this bone the 5 years. Excellent result to this bone. Good biocompatibility, and then the very good effect for the contour maintenance, and then good binding to the implant area. 됐고, 이거 잡아줘. Okay, this is the bio cover from the Prugo. 여기 셀라인 좀 봐줄까요? 셀라인 좀 봐줘요. 여기 보여줘요. 여기 보여. 여기 셀라인 보라고. 여기다 보라고요, 셀라인. 오케이. The upper left lateral incisor, I want to try the horizontal matrix suture. And then the upper right and lateral incisor, I want to try the bone tech fixation. 당기고 있어.
그대로 계세요.
First bone tech. For ultimate fixation, the bone tech is the best one. Right here. 여기다 살짝 대고. Okay, this is the upper left side. I want to try horizontal matrix. Because this is ridge splitting, ridge expansion area. So the moderate stabilization is okay. Okay, now I'll start suturing. 몇 분 지났어요? Usually for the good stabilization by the horizontal matrix, it require from the initial line, 여기 찍어. 여기, okay, 거기 꽉 찍어. 6mm is better. And then inside, the periosteum capture. And this silk press the membrane area. 찍고. 네, 인상 준비해 주세요. 컷. Okay, for the aesthetic result, some midpoint suture first. 찍고. Good. I think this is the routine operation for the upper jaw edentulous area. So the upper zone 2 area, as I noted before, so the molar and premolar area, the crustal dimension is relatively good. So you can try analog method or digital guidance. And then it's a very simple case. And then the anterior part, the zone 1 area, intersinus area, usually horizontal resorption because the central pital resorption. So that means analog surgery is better. Just like this surgery, the side cut drill for the make a bone indentation, no perforation to the plateau side, you have to check, and then very simple GBR. Sometime breech splitting, sometime GBR here. Maybe within 2 or 3 minutes, I can finish the surgery. And then right after surgery, I will take an impression for the fixture level impression by the prefabricated the 3D printing the individual tray. 찍고. 아버님 아주 잘하고 계세요. Almost done.
그거 안 쓰셨어.
Just please bring the duplicate denture and the individual tray. Today is the 2020, the April 21st, the Korean local time, about the 9 p.m., right? 아버님 목 쪽에 석션해드리고. 자, 이제 인상 뜰 거예요. 인디비주얼 트레이죠. 여기 드릴 1.2 헥스 드라이버. 자, 아버님 많이 보세요. 여섯 개 다 꺼내주시고. 내가 힐링캡 줄게. 오케이. 이제 없어도 되고요. 그냥 This 6 implant I already installed by the almost above the 30 Newton centimeter. So initial stability is good. So you don't have to worry about the micro motion during the healing cap insertion and healing cap takeout. 자, 몇 분 지났는지 체크해줘.
몇 분 지났는지 확인해
Okay, almost 3 minutes left. You can finish it by the own time. 어디 해보세요. Just engage one by one by your finger. You check the conical, the driver. 어디 해보세요. Okay, fifth impression coping. Holding the, please check the conical ceiling area. Okay, open please. 해보세요, 아버님. 잠깐만. 해보세요. Okay, this is the 3D printing individual tray. Briefly check here. Good. 여기다 테이프 붙이고.
네.
아버님 해보셔요. 자, 줘. 테이프 붙이고. 자, 주세요. 그냥 줘. 괜찮아요. 테이프 붙이고 주세요.
그대로 계세요.
해보세요, 아버님. 주세요.
주세요. 크게. 네,
잠깐. This is my routine technique. So the tape is very useful for the grossly individual tray by the pickup impression. You can holding 2 minutes more. Okay. This is the duplicate denture. 저 denture 줘볼까? This is almost exactly similar. And then by using this one, I will make a bite registration. So lower jaw impression taking, upper jaw fixture level. This is the bite registration. So we can get within 1 week, get a good, very stable, the vertical dimension, stable horizontal dimension for the immediate loading. Very similar to the old used denture area. Explorer. 힐링캡 준비하고. Maybe we have 10 or 15 minutes Q&A time, right? Okay. 해보세요. 해보세요. 아버님.
알고 계세요? 코로 숨 쉬시고.
마지막으로 블루무스 여기다 안에다 한번 쏴줘야 됩니다.
블루무스 떨어질 수도 있어요.
아니야 블루무스래. 이렇게 빨리 끄다. 영화 시간 때문에. 이거 잡아주고.
아버님 거의 다
드라이버.
됐어요?
드라이버. 아버님 아. 아직. 해보세요, 아버님. 이젠 아픈 거 없어요. 다 끝나셨어. 너무너무 잘하셨어. Okay, this is the pick-up impression. Okay, this is the bite registration. Bloomers, please. Because the intraoral situation is different before surgery. 꽉 물어보세요, 아버님. Okay, this is the very good bite registration. So this duplicate denture also provide very stable vertical and horizontal dimension. Okay, I finished this surgery, and then we will deliver the healing cap. Okay, after take a panoramic view, I will go to the podium for the answering your question. 해보세요, 아버님. 아버님, 아. (40) 몇 분 됐죠? 해보세요, 아버님. 아버님, 제가 처음에 계획한 대로 잘 됐고요. 고생 많이 하셨어요. 해보세요. 해보세요. 나가서 주사 한 대 놔드릴게요. This is the very wonderful patient. And then, okay, final healing cap. 해보세요. 드라이 꺼지 좀 준비해줘요. 뒷거리 걸어줘. 오케이. 바로 엑스레이 찍고. Finish? Good. Okay. I got many questions. Thank you for your wonderful question. The first question, Dr. Wanja, do you have any guidelines for the selection of the fixed level or abutmental impression for immediate loading? Wow, this is a very good question. Impression taking, actually there are 4 types, we know. Fixed level, abutment level, open tray, closed tray, direct, indirect, pick up and transfer impression. At this time, the first most strong factor is inter-implant angulation. So for immediate loading, usually lower jaw, you can take abutment level impression or cam level impression. But upper jaw, because of the divergence of the implant, each implant. So I strongly recommend fixed level impression is better. Second question, Dr. Andrew Tan. In this case, you apply the bone tech for the GBR. Is it really necessary? Okay, there are 8 techniques for the GBR stabilization. The 5 technique for the suture. Another 2 technique is the membrane hole with the insertion healing cap, sometimes collar tape covering. But final 8 technique is the bone tech fixation. So initially 5 technique, horizontal matrix, vertical matrix, modified crisscross 1, modified crisscross 2, sling suture. These 5 suture technique and membrane hole, healing cap insertion, collar tape. But compared to these other techniques, bone tech fixation most ultimate deliver the GBR stabilization. So of course, the bone tech fixation, resorbable membrane, non-resorbable membrane, both of them is necessary sometime. And this situation, of course, this is the immediate loading. So no pressure to the gum by the immediate denture, but for a more predictable result, sometimes bone tech is necessary. Only xenograft, third question, that's James Chan. Thank you. The xenograft or sandwich technique, of course, according to the thread exposure amount, sometimes only one xenograft, sometimes sandwich technique by the autogenous bond. But today's case, the upper left or upper right side area, thread exposure amount is very small. So today's case, actually, I confess, only xenograft is okay. But during the drilling, I got some the autogenous bond. So at the time, autogenous bond. But if you don't have autogenous bond, only xenograft is okay. Number 4 question, too many questions. Dr. Francis. Okay. Number 1 question, what's the dimension of the Langenbeck retractor? I like it. The Langenbeck retractor, it looks like this shape here. So this Langenbeck retractor is very effective for the molar area retraction, sometimes second molar for sinus grafting, or deep area of the lower area. This dimension may be around I didn't measure this one, but actual length is here. Maybe this finger, like this dimension. I like it. Because the Langenbeck or just the Aminebi retractor, there are many kinds of retractor, very similar this way, but this dimension, your finger, like this dimension, actual length. Okay, number 5th question, Akasha Baheti. How much distance do you consider in between the 2 implants? What is the minimum length for the 2 implant placement? 7 millimeter. Lower anterior except another area, implant, initial drilling, this 2-point area, minimum requirement 7 millimeter. Above 7 millimeter is better, but premolar area 7 millimeter, molar area 9 millimeter, second molar area 10 millimeter. We have to memorize. Sometimes 7, 7, 7, 7, 9, 10. Lower area 5, 6, 7, 7, 10, 11. That means 2 premolar drilling point. This dimension, minimum 7 millimeter is okay. Okay. Next question, what about soft tissue compensation for the length of the implant? At the time of the drilling or at the time of the local injection, at this time, you can evaluate soft tissue thickness. Maybe usually soft tissue thickness 2 millimeter to the 4 millimeter. So at the time of the drilling, and then after drilling, you can check by the probing, you can measure the soft tissue. So at this time, usually for me, the Fleming surgery, of course I comment. Just during a before implant placement and then implant placement by the fixture driver, you can see some line, right? This the highest line matches the soft tissue area. Implant depth control automatically 5 mm deep is okay. Okay, and the time is okay. Maybe the next 7th question: what basis did you choose the implant position? This is the it require too long time because the partial edentullism, total edentullism is different. Partial edentullism, what is the optimal implant position? That means midpoint of the tooth area. But edentulous area, we can make arbitrary the central incisor, lateral incisor, canine, first, second, first molar, second molar. We know the dimension. And then at that time also, so second information we can get from the opposing dentition. So at this time, from the, okay, I will comment 8.5, 6.5, 7.5, 7, 7, 10, 8.5. This is the upper natural tooth dentition, the major distal dimension. So with this concept, we can choose the proper position of the implant. It's okay? Okay, I show the case. Relatively good. So according to my initial treatment planning, I placed the 6 implant by the Flemley surgery, and then 2 implant by the flap surgery. One of them, GBR, the other one, ridge splitting. And then after surgery, I take an impression from the 3D printer prefabricated individual tray, and then the bite registration by the duplicate denture. Thank you, everyone. Okay.
Good evening, doctors. My name is Yong Seok. Nice to meet you. Before lecture, I want to comfort every people in the world who suffering coronavirus. I hope this disaster will end soon, and I hope to see you in Osstem meeting offline, face to face. Today, I want to show you a live surgery. Before live surgery, I will give you a short lecture. My lecture content is bone graft for sinus bone augmentation, timing of loading, and I will introduce live surgery case. Okay, first, the bone graft for sinus bone augmentation. I suggested new terminology related to sinus bone augmentation. It is SBA. So I will use the CSBA for crestal approach and LSBA for lateral approach, and CLSBA is combination of crestal and lateral approach sinus bone augmentation surgery. I started sinus surgery in 1996. During the past years, I experienced 4,800 sinus bone augmentation case. Current trend of sinus bone augmentation surgery is using a specialized instrument. We do CSBA without graft. This is current trend, and there are some cases which is indication of a lateral sinus surgery. It is not easy. So I recommend the CLSBA surgery for beginners. Okay, it is a combination of crestal and lateral sinus surgery. I want to show you this technique today. What is the mission of sinus surgery? It's very simple mission. We want to make vital bone in the sinus. This is our mission. Then how can we make bone in the sinus? This is the key point of sinus bone augmentation. First, we must separate sinus membrane sufficiently to provide space and blood clot formation and bone cell supply. This is first key. Second key is keep the space to prevent re-pneumatization. Okay? We can prevent re-pneumatization by grafting or sometimes just placing implant. When is the bone graft necessary? In case of sinus bone augmentation, depending on remaining bone height. When remaining bone height over 5 millimeter, usually no need graft. In case of less than 5 millimeter remaining bone height, narrow sinus maybe no need. But in wide sinus, we need some graft. There are many kinds of graft material available, from autogenous bone to allogenic, genogenic, and alloplastic material. Is there any difference in sinus bone augmentation outcome depending on graft material? Here is a systemic and review and meta-analysis article. On conclusion, this article said implant survival seems to be independent of the biomaterial. Okay, because sinus is a relatively contained defect which has good healing potential. However, there are some risk factors of sinus bone augmentation. One of them is width of sinus. Narrow sinus is when you consider innate healing potential, narrow sinus is good healing potential. However, wide sinus has poor innate healing potential. Narrow sinus, it is easy to separate membrane and grafting. However, it is difficult in wide sinus. In the point of speed of bone cell supply, narrow sinus, we expect very fast bone cell supply. However, wide sinus is very slow speed. In the point of outcome of bone formation, narrow sinus is predictable, but wide sinus unpredictable. So, when you have a patient who has wide sinus, the prognosis is unpredictable. It is a difficult case. We need a reliable graft material in such a wide sinus. Generally, graft material is not critical. However, in wide sinus, good material will show better outcome. Next, the timing of loading. It depends on residual alveolar bone height and quality, implant stability, and speed of graft material change to bone. Okay, generally speaking, timing of loading will depend on remaining bone height and the stability of implant. For example, when remaining bone height 2 to 3 millimeter, at that situation, we can start the loading about 5 to 7 months, depending on primary stability. This is general rule. For predictable result, it's better to use such a nice device, Osstem, which display the number, indicate timing of loading. The company said when ISQ value exceeds 72, we can start loading. So based on ISQ value, we can do timing of loading. So, okay, for example, here is remaining bone height more than 10 millimeter, 5 millimeter, less than 2 millimeter. We can do sinus surgery in such a situation. In case of very normal ISQ, the implant stability, 30 to 40 Newton centimeter, generally we can expect such a ISQ value. In case very poor, less than 10 Newton centimeter, ISQ value will display like this. Then when we measure the ISQ value, bone material will change to bone and it increases the ISQ value like this. Generally, in my old experience, I found that About 6 months later, when patient has less than 2 millimeter bone height, I expect 60 to 70 ISQ value. Then, so many kinds of graft material available. Which is better? Everyone agree autogenous bone is the best. And how about other material? Here is allograft material and compared with xenograft material. Usually, allograft material is better than xeno, and speed of bone formation also better than xenograft material. Then, my experience and my choice of graft material, if possible, I use autogenous bone. If I cannot, maybe BIOS, very nice graft material, reliable, predictable material. And a mineralized allograft is good also. And recently, I'm using an organic porcine bone. It is also xenograft. Maybe it's comparable to BIOS. This is case who grafted allograft. And look at the ISQ value 6 months after the operation. I performed the second stage surgery, then ISQ value around 60 to 70. It's the usual expected ISQ value. I found this material and surprised because the ISQ value was really raised up very fast in this material. I compared the xenograft and allograft. Generally, allo is faster than xeno, but not in this case. I performed both sinus surgery in patient who has remaining bone height 1 to 2 millimeter, both. And 3 months and 2 weeks later, I performed the second stage surgery. It looks too early. However, look at the ISQ value. Allograft 60s and xenograft 70s. Okay, just 5 months later, I found that all ISQ value exceed 80 in xenograft. It is really faster bone formation. Another patient here, 61 years old female patient who has very less bone, 1 to 2 millimeter, and even 27 less than 1 millimeter. Well, I performed the surgery in this patient. I grafted xenograft, the graft, and submerged implant. Well, look at this case. I performed the second stage surgery 2 months and 2 weeks. It looks too early. However, okay, one more thing is that I tried the depth control during the second stage surgery. Look at the ISQ value change. 2 months and 2 weeks later, 26 implant, 27 implant, around 60. It's not bad. Just 2 months, 2 weeks later. And 5 months later, okay, 77, 75. Look at the second row, the red color. That time I tried depth control. I intentionally turned, so it decreased the ISQ value. However, just 2 months later, it increased to 70. Anyway, this is before and after operation. Today I want to do live surgery, and I will present my case. It is a 71-year-old male patient who missed multiple sites. Okay, in panoramic view, the remaining bone height on the right side looks not bad, but left side looks around 3 millimeter bone height, and here mandible is missed. This is clinical view. It's healed soft tissue. And sinus looks not wide on the right side. Okay, number 16, 7.6 millimeter. Left side, remaining bone height around 3 millimeter, and wide sinus. This means that we need graft. Mandible is simple. So my plan today, I will perform surgery like this. First, on the right side, I will perform flapless CSBA surgery, and I'll place 2 implants, 5 and 6. Left maxilla, I will show you CLSBA surgery, combination of crestal and lateral sinus surgery. I'm planning 2 more implants. And last, in left second molar. With a flap wrist surgery, I will place short implant. Okay, it's my plan. Okay, okay. Wish me luck. I'll start right now. 자, 이렇게 하고 갈까요? 조금만 뒤로 빠져볼까요? 조금만 뒤로 빠져봐요. 조금만. 오케이, 됐어요. 오케이. I will start the surgery and I will add some anesthesia. 안 서둘러도 돼요. First, I want to show right side. I'm planning C. 이거 뭐지? 4.0인가? 하악인가 이게?
네.
4.5인가 이거? 이거 보세요. 이거 얼마예요?
4.5에 7, 4.0에 10.
Okay. Okay. First, I will try right side. I'm planning CSBA surgery, and I will not open flap in this side. 자 보세요. 앞에. I will mark entry point. 있어요. Here 5. Left turn please.
왼쪽 보고 내세요.
물이 나와야지. Okay. Keep coming. 5 here. It should be very close to number 4. And this is 5 and 6 here. Maybe we need a sinus surgery at number 6. 자, 빼고 다음으로 보세요. Close, please. Okay, I'll extract the right second mandibular molar, and here I'm using cast drill. I'm not sure how much is the bone height at number 6, so I'll start with the here 7mm stopper. I must be careful not to perforate membrane. Let me check the penetration sinus floor with the is that past? 코 풀어보세요. Blow your nose. I'm not sure. Oh. I surprised because at first drill I found sinus flow past. Maybe 7mm stop was too long. I will change the 6mm and I will check again. Maybe bone height was not so much at number 6. Already passed, and I will try the El Salvas maneuver. Blow your nose, please. It perforated. Oh, this is live surgery. What should I do? Okay, any idea? Okay, I'll try number 5 first. It was excellent. Anyway, I'll solve the problem first. Okay, 5 first here. 5, and maybe it is not passed. So I will change it to 8. Why? Okay, this is 8 millimeter stopper. And let me check with 9 millimeter. Where is it? Here. No, not this one. This one, 9 millimeter. I'm checking number 5. What should you do when you experience such a problem? I will use 3.1 cast reel with 9 millimeter stopper. I'm trying to do crestal sinus surgery, and it perforated number 6. What should I do? Not yet. Okay, I'll finish number 5 first. 10 millimeter. And this is 11. Not yet. Number 5 looks much bone height. This 11 millimeter stopper. And 12. This is last. Almost. I passed here. Maybe next time it will be fully passed. It is not completely passed. Try again here. Okay, then. Okay, without stopper, carefully check floor. Maybe passed. Then I'll try hydraulic lifting with a saline. Let's separate membrane. 가져와요. 가까이. 잡아줘. 리트랙션 해줘. 앞에 잡아줘. 앞에. I will separate membrane. Okay, it works. Okay? 이거 가까이 줘야지. Okay, as you see, it works like this. 코로 물이 넘어올 수 있습니다. Number 5, I separated membrane. Okay, number 5, I separate membrane. Then I will place one implant in here. Yeah, first I will place one implant. Change the speed, and 4 by 10 millimeter implant will be placed. 내가 몇 시 시작했나? when? Here, one implant at premolar. It looks very high, prime stability, maybe more than 40 Newton centimeter. I will control depth slightly. Not bad, good prime stability. During the crustal approach, sometimes you may experience membrane perforation. What should you do? There are several options.
이제 10분 되셨다고.
Yeah, there are several options. Close, please. Close. 다음으로 보십시오. Okay, not bad. This time, accidentally, membrane perforated. Membrane perforated. What should you do? I'll show you how to solve it. Although this is not a usual situation, I can show you. Maybe it will be very controversial in such a technique. Open, please. I'll enlarge the hole slightly further. And then 어디 갔지? Where is it? Mount drive. 아니. 여기. I'll place implant here. I'm planning 4., 근데 내가 할게 내가.
아, 네.
4.5 implant. Okay, like this. It is not fully inserted. About this. Okay, open please.
안고 계세요.
close. 살짝 다물어 보세요.
30분.
Okay, not bad. 보세요.
네, 보세요.
I control the
자,
path and position. I control the path and position. Okay. Well, right side I will control later. Okay. I will give you a quiz. How to control this side? It perforated. I placed implant. Is it okay? Okay, I'll show you this one later. I'll show left side first. 그렇게 하면 안 돼. 스톤을 본인이 잡아야지. 오른쪽으로 보세요. 오른쪽으로. Turn right side. Okay, let's try left side. 다음으로 보세요. Close please. 자, 나봐요. 이렇게 잡고. 손을 바꿔야 되나? 손을 바꿔야 되나? 이게 낫지 않나? 그렇지? 훨씬 낫네. I will open the flap in here. Like this. I don't want to open a lateral window on the right side. Left side I will open. So I made incision for routine lateral sinus bone augmentation surgery. Maybe left side I made the bone height too much. I thought it was too much bone height, but in reality it was not there. Bone height was not so much. That's why it perforated directly. Okay, I'll try left sinus bone augmentation. Okay, open flap. Patients wearing RTD as a result, the flap looks adhered. So difficult to raise up. Okay. 조금 더 오른쪽으로 보세요. Right side. Right hand please. Okay, 좋아요. Then look at the center. And I'm gonna do crestal sinus surgery again. I'll try again. I will use the casket. And bone height was only 3 mm, so I'll safely start this time. This is 3 mm. Well, we can do 2 mm, but maybe bone height is more than 3 mm. I can.
물입니다.
This is 6. And again, I will use the same stopper. It is 3 mm stopper.
자, 보시면
물이 떨어지나? Moving. Okay, good. Got it. Then let me check the penetration with the depth gauge. And it is a 4 mm stopper. Oh, already? Not yet. It is not passed yet. Then I will use 4 mm stopper, cast drill 3.3, stopper 4 mm. And then check with 5mm stopper. Where is it? Here. Okay, here, 5mm stopper. Here. Passed. Blow your nose. 코 풀어보세요. No, it is not perforated now. Then, let's try again. Let's try hydraulic lifting. Okay, seal the hole. And then inject saline, pull out, inject saline and pull out. Why it does not come out? It should be come out. 코 풀어보세요. No perforation, but I cannot see the saline withdrawal. Again, I'll try. It's unusual situation. 자, 플랩을 여기를 잡아야지. 여기를 잡아주고 I will seal the hole tightly and then inject the saline, pull out. 코로 물이 넘어오나요? 코 풀어보세요. 풀어보세요. It looks not perforated. There's negative blow. Okay, 코 풀어보세요. Okay, let me open the window. Change, please. I'm not sure. This is not usual. Okay? Generally, during the hydrolifting, saline will advance smoothly, and when I withdraw it, it should be smoothly pulled out. But not in this case. I'm not sure why. If I open the window, I can see what happened. 물을 뿌려야 되나 입혀서? 됐어. 이걸 할까? 오케이. 라이트를 좀 맞춰주시고. 자, 이제 담으세요. 오른쪽 보세요. I'll open lateral window in this case. 자, 내가 좀 잡아줄게. 잡아요. 포지션을. 이렇게 잡고, 이렇게. 오른쪽으로 보세요. 오케이. I'll open the lateral wall. Like it's routine lateral sinus surgery. Gently scope on window. Okay. Let me check. 천천히 하세요. Okay. Second. Not in here. Maybe this patient has a very thin membrane. Okay, then let me fracture the window. Not okay. Done it. Here I fracture the window, and I will keep this window in normal saline. Here. Maybe it's okay. Okay, now let's check the membrane. Well, no big change. This means that maybe there is any pinpoint penetration, so it does not separate with the hydrolifting. Then I will try routine membrane separation. With the instrument. Okay, start the distal, center, and the anterior, and the medial sinus wall, like this medial sinus wall. Membrane separated well. Look at the condition. Can you see any perforation? Can you see? Cannot see? I'll try Birasalvas maneuver again. 코 풀어보세요. Here we can see a pinpoint penetration, maybe, but not really. 코프로 보세요. No problem, no problem. It looks not perforated. Okay. Okay, I separate membrane like this. Okay. Then let's try bone preparation. I'll place 6 and 7 guide를 오른쪽으로 보세요. Open please. eye 보세요. 잡아줘요. 오케이. 2번 섹션. 됐어요.
고개 오른쪽 보고 계세요.
됐어, 안 뿌려도 돼요. 6 here. Already perforated. Test. And 7 here. 뭐 연줄 제거해야 되겠다. I remove the soft tissue. Sometimes CLSBA surgery looks very fantastic. Since membrane already separate after the hydrolifting, but not in this case. Okay, not in this case. This case, membrane didn't separate well after hydrolifting. Okay. 이 섹션을 조금 더. Here is 6 and 7. Okay. Okay, I pass the floor. Bone is not soft, not so soft. It's good. Okay. Usually I do under preparation on the maxilla, so I very simply pass the hole. Okay, done. Then let's graft. I have to use graft material. 더 graft 줘요. 더 graft 어디 갔어? 하이트 안 줬나? 더 graft를? 0.5g. 그거잖아, 그거. 그거 맞잖아. 빈각이라고? graft material, please. 줘요, 더 graft. 자, 석션 해줘, 여기. 잠시만, wait a moment. 풀어요, 다 풀어. 뭐야, 그 3분 2만. 더. 됐어요? 셀라인. Okay, I will grab the material here. 다 줘요, 다 줘. I like using reliable grafting material in such a wide sinus. So in this case, I will use one genograft. Okay, 여기 날 도와줘야 되겠어. 도요. 본인이 석션을 들고 있고 잠시만. 담으세요. 본인 이거 잡아달라고 이렇게. 잡고 이거 잡아줘요. 이거 두 개를 잡으면 석션을 주고. 됐습니다. Okay, I will grab the bone in here. So I will carry and insert into the sinus. Ideally, I like syringe type graft material. This is bottle type, so a little bit inconvenient to graft material. This company has also syringe type graft material. It is not supplied today. Okay. How much? It depends. It depends. In the past, we tried to graft much more than implant height, but it is not always necessary. I just simply fill the graft material. Okay. 플랩 잡아줘야 돼. 플랩이 안 잡혔어. 뒤쪽 플랩. Okay. Okay. Spread the graft material. Do not pack it. Just simply fill it. Okay. Like this. Now finished. Okay. Almost done. And I will place implant and then finish the lateral side. Okay, let me place implant here. I will place 4.5 by 10 millimeter implant. 놔버리고. 아, 크게 해보세요. Okay, speed changed already. 아, 크게 해보세요.
고개 오른쪽 보고 계세요.
Okay. Well, torque is good. Because of under preparation, insertion torque is not bad. Around 30 Newton centimeter. Not bad. Okay, one implant placed. Close, please. Close. Okay, good. One more. I'll place one more 4 by 10 millimeter implant.
좌에 보세요.
크게 벌려보세요. 오른쪽으로 보세요. Okay. Okay. Also good insertion torque. In this case, 빼봐요. I will not connect the healing abutment in this patient. When I just look at the insertion torque, it is enough to connect the healing abutment. It is more than 30 Newton centimeter. However, patient is wearing removable denture, so to avoid accidental loading, I will not connect the healing abutment. Sometimes we can do relining of inner surface of denture and connect healing abutment, but this patient is wearing RPD, which is metal based, so it's very difficult to control. So I decided to submerge implant. 커버 스크류 다 꺼내줘요. 다 꺼내놔줘 이게. 4개 다 꺼내줘야 돼. 픽스 드라이브. 예. 이거지? 오른쪽으로 보세요. I have to control depth carefully. Depth is not enough yet. Suction, please. 여기. Depth 봐야 돼, depth. 보여줘. I cannot see. Suction 해줘, 주변. Okay. When patient has thin soft tissue, that's the problem, because we cannot control depth easily at that situation, because in case of thin soft tissue, we need a deep implant installation, but it is difficult to insert implant sufficiently. In sinus case, implant may be dropped into the sinus, so that's the problem. During my lecture, I shown depth control during the second stage surgery. In case of thin soft tissue, less bone, I do that. I do depth control during the second stage surgery. This time I cannot place implant deep enough. Then next time, after bone healing, I can insert implant. Maybe not bad now. Total depth is not bad. Suction. Okay, then I will connect the cover screw. Torque is good. cover screw 준비해줘요.
14 minutes.
얼마 남았다고? 13분 남았다고? Only 14 minutes left. I'll finish left side first. Today, accidentally, we have a accidental situation on the right side. Although I thought the right side will be very simple, but I experienced one accident. Close, please. 다물어 보세요. Okay, that looks not bad. I will simply reposition window and approximate flap. Okay. Let's reposition. 놔보세요. Okay. Let's approximate. 봉합. 주세요. 자, 자, 보세요. Maybe I'll simply approximate.
보세요.
보세요. I'll hold several suture first and 앞쪽을 잘 잡으죠. 앞쪽이 안 보이죠. 오케이. Approximate the corner first. Interior, vertical. Sometimes surgery will run very smoothly, but sometimes there's accidental situation which makes me trouble. Then what should I do? I must solve that case also. Nadia. Not good. Not good. Hesitate. I have to hurry up, so it makes waste.
라이트 한번.
Change light. 이렇게 해주고 버티컬 당겨야 되는데 안 당겨졌어 지금. 버티컬 당겨야 되는데. Okay, good. Today my plan was 4 implant, right 2, left 2, and 1 mandible, 5 implants, okay? But maybe because of time, I cannot show left mandible because I must solve the problem on the right side. Okay, suture is not important. I will finish suture after this video. I want to show the right side. Mandible, simple. Flap surgery, very simple. I have to solve the right side. The right side have problem. Membrane perforated. What should you do? Okay, I'll show my solution. Bone height is not sufficient on the right side, and I will start 4mm stopper. Where is it? Where is stoppers? 스탑 다 돼가 저기 스탑 다 돼가 버렸냐? 이거 다 갖다 놔버려. 이쪽으로. 4mm. Carefully, I will try to access to number 7. Very carefully. And where is it? 2.8. 2.8. Where is 2.8? 2.8. Okay. And the 4mm stopper here. Where is 4mm? 5mm stopper. Okay, here is 5mm stopper. I will pass again carefully. Inside.
왼쪽 보고 볼게요.
Then depth gauge 6mm.
고개 조금 왼쪽으로 보시고.
Not yet. Then I will use 6mm stopper. Number 6 has very less bone. check with a 7mm stopper. I need a blade. Where is blade?
나이프 한 번만.
혹시 아프시면 말씀하세요. 피 입서지? Oh, it is very dense. I will try again. Okay. I want to see the hole. See the hole. Flap is very tightly adhered on the bone, so that's why it is difficult. I'll try again.
자, 크게 해보세요. 눈입니다.
Okay. And check again. Number 7, bone height not bad.
자, 크게 해보시고요.
Maybe passed. Passed. Okay. 퍼프로 보세요. Okay, this is not perforated. Then I will try. Hydro lifting. Mosquito. Go. Retraction place. And then seal. And inject the cell line. Pull out. Okay, now it works. Push, pull out. Okay, like this. It should be like this. When I do hydrolifting, it should be like this. This means that membrane separating. Membrane separating. Like this, okay? I performed the hydrolifting from number 5 and number 7. Then, how about number 6? Maybe number 6 also separated. Okay, that's why I did this. I tried this. Let's control depths. I lock place number 7. Let's control depths of implant. Okay, disconnect mount. In this case, there are several ways to solve the perforation during crystal approach. One is short implant. Short implant means that when patient has more than 6 millimeter remaining bone height, that time, even if perforated, I don't care. I just simply place 7 or 8 millimeter short implant. Then implant will be survived. However, fixed drive. When remaining bone height is less than fixed drive, less than 5 millimeter, we cannot do that. Just with a short implant, it is unpredictable. We don't know how this dead implant will survive. We don't know. So we need another solution. The one is open lateral window, and then place do lateral sinus surgery, open window, repair the membrane, and then continue sinus surgery. Maybe this case is indication of this situation. When
왼쪽 보고
this patient is less bone height, maybe less than 5 millimeter, maybe, because he perforated early, so bone height is not sufficient. We need lateral access. But as you know, many dentists who do crestal sinus surgery cannot do lateral sinus surgery. Then, how can we change the surgery? At that situation, my recommendation is just close the flap. Okay, just close the flap and delay the operation. That means about 2 months later, membrane will repair spontaneously. Then we can do another crestal sinus bone augmentation. That is the routine recommendation to my trainee. If you cannot do lateral sinus surgery, delay the operation. But this time, as I shown, it is not usual recommendation. It is not usual recommendation. Unofficially, I do this. Okay. Although I shown this type of surgery, don't follow. Please don't follow. Okay, I'll approximate this one. I connected the cover screw also because it is also under the metal-based RPD, so better not connect the healing abutment. We'll approximate flat. Time out? Time out이죠. Is that time out? 계속해요? Should I continue? Time out? No. Oh my God. Time out. I couldn't show left mandible. And tissue process. I have to check the hole again. 자, 코프로 보세요. Okay, no problem. Okay. No positive blow. 코프로 보세요. Okay, no problem. Okay, I finished right side and left sinus. I didn't close yet, and I didn't finish the mandible. It is flapless surgery. Well, what should I do? Finish or continue? I'm not sure. Okay, I'll simply place one implant in mandible. It's very simple as in reality. Turn right side. eye 보세요. It is flapless surgery, so it's very simple. I'll place a short implant in here. I'm planning 7mm long implant. But because of slope, bone slope, I will use 8.5 long drill. Okay. I have to check the flow with the depth gauge. Okay. Okay, it is safe. 0.5 by 7mm, 4.5 by 7mm I'll place here. Last drill, 4.5.
이제 조금 오른쪽 부분
Implant.
네, 오른쪽으로
네.
살짝
마운트
돌려보세요.
드라이버,
이거
롱.
따라오시면 안 돼요?
7mm. I'll place 4.5 by 7mm implant in here.
기다려주세요.
Okay, good. Good insertion torque. Then let's finish. I'll disconnect the mount and prepare fixed dry, please. 주세요. I'll control depth sufficient. Look at this line, this laser marking system. The top of that laser marking is 5mm. I will insert the implant about 5mm in here. Okay, can you see? Can you see the laser marking? If you can see, it should be deeper. 됐나요? Laser marking, upper. Almost done. I will connect the healing abutment in here, 6 or 5 here. Maybe there's chance of interference during the healing abutment connection. because I placed the implant deep, okay, I can feel the interference on medial side. This means that bone height on medial wall is higher than distal. So to solve such a problem, I will use bone profiler. Okay, here, simply I will use bone profiler. Connect guide first, okay, and then after connecting guide, I will use bone profiler. 가이드가 안 연결 안 되지? 가이드가 미니인가? 왜 연결 안 돼? Why I cannot connect guide? Okay, maybe this is mini. It should be regular. 그래서 okay, this is mini. It should be regular guide. 석션. 조심해서 석션해야 돼. 안 보여. Okay, here it is. I'll connect the regular guide, and then I will use bone profiler. Here. Don't put it there. Okay, simply, we can grind the medial wall, medial bone. Disconnect. And I'll try to connect 605 healing abutment again.
열어볼게요.
605. 7 is better. Because of depth, 7 is better. Here. I'll connect the 607 healing abutment in mandible. Okay, done it. Now I can connect healing like this. Okay, total depth looks more than 5 millimeter. That's why 7 healing is better. Let's approximate flat. Nylon. 아니, 찾아봐, 나일론. Where is it? Cannot see. 하나 더 줘. 오케이, 자, 석션해줘. 석션해볼까, 여기? 석션하고, 여기 앞쪽 석션하고, 뒤에 석션하고, 잡아줘요. Okay, I'll finish. I'll spend a very short time. Okay. For beginners, it's better to submerge the implant. If you connect the healing abutment during the sinus surgery, flap approximation is also complicated. So, for beginners, better to connect cover screw and do staged submerged surgery. Okay, one more, just one more. 오른쪽 보세요.
조금 오른쪽 보시고.
다 됐습니다. 거의 다 됐어요. Okay, last stitch. Okay. There was accident. Not good. 긁었죠? I have to one more. 긁고 하나 볼까? Okay, let's finish. 오케이. 다 했죠? 앞쪽에 다 했죠? 오케이, done it. 이리게이션. 고생하셨어요. 예. 파노라마 찍어줘요. Because I didn't watch the depths exactly at the panoramic view, I can control depths if needed. 오케이. 빼주고. Okay, thank you for watching. The surgery didn't finish smoothly. There was some accident. Anyway, there are several questions from dentist, my colleague, from here and there. One question by Dr. Matthew Lee. He is in Australia. Okay, he asked me, what is the advantage of CLSBA surgery? Well, in reality today, I want to show the advantage during live surgery, but it was not smooth. Usually, I recommend the CLSBA surgery in hard lateral sinus surgery case. For example, thin membrane or irregular sinus flow. This means that there are chance of membrane perforation. But if you do crestal approach first, you can separate membrane with a hydraulic pressure. Then membrane will be already separated. So during the lateral sinus surgery, there is less chance of membrane perforation. Although this case didn't separate membrane dramatically, but maybe this is advantage to beginners who worry about membrane perforation. Okay, thank you for asking me. And wait a moment, I must see the okay, Dr. Arias, I don't know where he from, asked me, how do you know the membrane is separated? Well, during the hydrolifting, we don't know. We cannot see, but in normal situation, when I inject the saline and pull out the water, it will be come out as a whole volume. This means that membrane separated by hydraulic pressure and pulled out. And we can see the color change. At the last right side, last 7 implant side, I shown the result. It is reddish, it is coloration. This means that when I inject saline, pull out, membrane separated. So watching that phenomenon, I can inject the saline and pull out, and the reddish discoloration, I know this membrane is separated. And after operation, I'm taking CT. Then I can see the membrane change. Okay, generally dome shape, elevation. That is the evidence of membrane separation. And one more question. Maybe it related to the kinds of graft material. Generally, during the sinus surgery, kinds of graft material is not so important because of innate healing potential. In my case, the right side, I didn't graft it because it is narrow sinus. Narrow sinus has good healing potential. Just feel the blood clot will turn to bone. But in the left side, it is not like that. It is wide sinus. Such a less bone with wide sinus, we must make bone. Without making bone, implant cannot be survived. So just with hydrolifting, membrane cannot be supported. It will drop and re-pneumatized. So that time I must graft. In my experience, generally after graft, result is good, but not always. Sometimes in wide sinus, less bone, some kind of graft material does not make bone. In case of such a wide, less bone height, sometimes graft material is critical. So that time I must use reliable graft material. Autogenous bone is the best, but it is difficult to harvest. Then what kind? Allograft material, good, not bad. But not every country allograft is available. Then you have only two kinds of material. One is xenograft, another synthetic material. I don't believe synthetic material. Many companies now introduce the synthetic material, BCP, biphasic calcium phosphate. It's unpredictable, depending on manufacturing. So I don't like synthetic material. Instead, I like xenograft. Maybe everyone know by us best, okay? And it is available in every country. So I also like by us. But also we know that the price of BIOS is not good. It is expensive. So I tried to replace another xenograft material many times. I compared many other xenograft material, but the result is not the same as by us. And finally, I found one thing. It is porcine bone. It is not bovine bone. I used that graft material this time, the graft. This is really nice. I surprised. When I used this graft material, the speed of bone formation is even better than allograft. So now my main graft material is this graft material. So generally, graft is not important, but in hard case, graft is critical. Better to use good graft material. Okay, maybe the graft looks a nice material. Okay, there are so many questions about because our time. Okay, I'll one more. When already I experienced the time grafting or no grafting, I said during the crystal approach, generally I don't graft because many cases bone height is more than 6 millimeter. That time, no need to graft. Okay, I only consider grafting when remaining bone height is less than 5 millimeter, and when it is wide sinus. Even it is less than 5 millimeter, it is narrow sinus, no need to graft. Okay, only less than 5 millimeter plus wide sinus, I consider grafting. Okay, okay, it's my answer. Okay, I'll finish. Panorama. Okay, I want to show the POP panoramic view. Okay, this is okay. Left mandible simply finish the left side with a bone graft material, 2 implants placed well. Right side, accidentally, membrane perforated at number 6. It was my mistake. I measured the bone height incorrectly. As a result, direct drilling. When I used the 2.2 twist drill, it perforated. So I tried to solve the problem. The key is space making, okay, for bone formation. So I want to separate membrane. I engage the implant to seal the number 6 and from 7 separate membrane. Maybe it will gather and membrane is separated not in 5, 7, but also number 6. Okay, in the future, maybe about 6 months later, I can see the change of bone formation. So with the website, I will post the result in the future. I promise.